Hello, everybody, and welcome to a stroke review with Dr. He. I just want to let you guys know that it looks like there's three of us here, and we are going to get this recorded and then sent out to your training officers. Hopefully, you guys will be able to get your hands on this. I believe there'll be a lot of good information here. I'm DJ Foister. I'm the director of EMS Outreach, and I know I've met most of you. A little bit about Dr. He. She's a cerebrovascular neurosurgeon from Anchorage Neurology Associates and board certified with the American Board of Neurological Surgery. She went to medical school at Case Western University of Medicine in Cleveland, Ohio, and did a residency and fellowship training at Vanderbilt University in Nashville, Tennessee. She's fellowed in endovascular and operative vascular at Beth Israel, Deaconess Medical Center in Boston, Mass. She is affiliated with Alaska CyberKnife Center, Alaska Gamma Knife Center, Alaska Regional Hospital, Creekside Surgery Center, and Providence Hospital. With that said, I also have Tammy Speed here. Tammy is our new director of stroke services. So I will pass it over to Tammy and let her kind of introduce herself to y'all, and then we'll get going with the presentation here.
Hello. Thank you, DJ, for that. I have been in the stroke coordinator position for exactly 2.5 weeks. And my goal is to get it from a primary to a comprehensive service line. So that's what I'm going to be doing. A little bit about myself is 6 weeks ago, I moved from Florida up to Alaska. And I've been a nurse for almost 30 years. I've got an MBA and an MSN. And am looking forward to working with everybody so we can go forward.
Awesome. Thank you, Tammy. And we're super excited to have you here as well. Dr. He, I'm just trying to do one more thing here real quick. That should mute, trying to mute it if people do end up joining. And I guess we can cross that bridge when we go. So
Okay.
I'll turn it over to Dr. He, and thank you, Dr. He.
Not a problem. And I just want to confirm, when I look at this, it looks like I'm sharing slides. It says stroke thrombectomy case review. Is that what you guys are seeing too?
Yes, that's what I see as well.
All right. So thanks for coming to the second inaugural stroke thrombectomy case review. Sorry for any ambient noise. I'm sort of hiding out in the physician's lounge right now. I have no, let's see, disclosures, financial conflicts of interest or otherwise. I am credentialed at both Providence and Alaska Regional Hospital and perform procedures and surgeries at both hospitals. We'll do a little bit of background stuff. The format will be similar kind of to what we did back in May. And so we'll talk a little bit about stroke thrombectomy. This will be kind of a review for anyone who was at that first meeting. We'll talk a little bit about pre-hospital screening for LVO in particular. One of the themes that's come up sort of with these 5 cases has actually been distal thrombectomy. Several of these cases fall into a category that has become more burgeoning in terms of patients who had, occlusive arterial clots that are not traditionally thought of as being, within the proximal large vessel occlusions, but still have pretty significant neurologic deficits. And this is something as a field, I think we're going to see more with. I have kind of mixed personal feelings about it, but we can talk about that. We'll talk about case review of the cases that we have, and then also updates from a couple of the cases that we had covered actually back in May. And then, any questions or anything like that arise. So stroke is, by definition, the sudden death of brain, matter from a lack of oxygen caused by either blockage of blood flow, which would be an acute ischemic stroke, or the rupture of an artery to the brain. The main thing with regards to stroke is that acute ischemic strokes are by and large the vast majority of strokes. They, are the cause of 1 in 20 deaths every year in the United States. One occurs every 4 minutes. And the one thing about ischemic strokes is that while the blood vessel or the blockage exists, ongoing continued damage to the brain occurs. With hemorrhagic strokes, once that blood clot has been there, once the bleeding occurs, so long as the bleeding does not continue to grow in size, the damage has been done, and it's just a matter of sort of managing the symptoms and the sequelae associated with it. Stroke, as a whole, is a huge cost burden on the health system. And so anything that we can do to sort of improve outcomes is long-term going to be beneficial both to patients, but also to the burden of healthcare costs, and also for quality of life for those patients as well. So this is old data again from the CDC. The stroke density basically for Alaska looks very similar to that of what we call the stroke belt, which is in the southeast region here. Many of the same characteristics that we share with patients in the southeast, including a lot of atherosclerotic disease, a lot of smoking, a lot of drinking, high-fat diets, lack of access and care for primary care, and preemptive and protective things also exist up here as well. Okay. So large vessel occlusion. So LVO is in particular what we're going to talk about basically. And so this is defined as a clot or thrombus within the quote large intracranial vessels. So meaning at the ICA terminus over here, within the proximal branches of the MCA, so what we call the M1 or the M2 branches, or within the basilar artery itself. Okay. Extracranial ICA occlusions can also occur, meaning they may have what's called a tandem lesion, meaning they may have a clot inside of the brain, but may also have some sort of a blockage limiting flow that's going from the carotid artery in the neck all the way up into that circulation. That's actually a fairly common finding as well. When we talk about distal thrombectomy, we're talking about branches that are further out from where we call these M2. So they may be branches that are here within the sylvian fissure, or even sometimes going already out to the cortical surface of the brain. Okay, we'll talk about that in a little bit. So what's the big deal with ischemic strokes and large vessel occlusions and everything else? So basically, 80% of all strokes are acute ischemic strokes, and 20% of these are what we call large vessel occlusions, meaning basically that a plug forms proximally somewhere here. And remember what we talked about, so long as the blood clot is there, there's ongoing damage to all that tissue that is at the far end or distal to the clot. So if the clot is here, it means that everything over here is not getting blood flow. And so there continues to be ongoing damage that occurs to the brain because of the lack of oxygen and the lack of overall blood flow. TPA in these situations only works less than 20% of the time for patients with known large vessel occlusion. Okay, the natural history of a large vessel occlusion in the MCA or ICA terminus is generally catastrophic and in life-altering, if not life-ending in many situations. And the most important thing, just like with cardiac patients, time is brain. So 1 to 2 million neurons or brain cells die per minute as cerebral blood flow and oxygenation is compromised. Okay. The main thing with this is that not all tissue is forever dead and irreversible. So in all cases of stroke, we have this area called the core infarct, which is, this is an area where the cells have basically been without oxygen for so long that they have undergone irreversible change. Okay, this is called the core infarct. And these are areas that no matter what you do at this time period, nothing is going to reverse this damage. Okay. There's a second set of cells that are undergoing what we call an ischemic penumbra, okay? This penumbra is generally larger than the core infarct itself. And what this means is that these cells are sort of somewhere along a phase or a spectrum, where some of them are undergoing, cellular change and death and apoptosis. But if we can reestablish normal blood flow and oxygenation, many of these cells will be recoverable and salvable, okay? And then there's sort of the normal brain, basically. What we don't want is this core infarct to be the same size as the penumbra. In situations like that, it means that there's not enough of a mismatch, meaning there's not enough potential reversible, salvageable tissue for us to save compared to what is already dead. And those are patients that are not candidates, even if they have a large vessel occlusion. How we determine the size of a core infarct versus the ischemic penumbra is with perfusion imaging. Okay, perfusion imaging at its heart is just a glorified and slightly different version of a CT angiogram. It's done with a slightly different protocol, and then you have sort of post-analysis that occurs from proprietary software from these different companies. Rapid is the one that we use here for both Alaska Regional and also Providence, that helps us calculate what these are. We have to remember, though, these are extrapolations. The computer is basically just taking data and based on various things that it sees is extrapolating what the core infarct versus the ischemic penumbra is, okay? What we're trying to prevent basically are patients that, have established infarcts like this, that then go on to continue to have, herniation and edema that require decompressive hemicraniectomies that still continue to swell, okay? This is the natural history of a large vessel occlusion in like the ICA terminus or the MCA, okay? And this is what we're trying to prevent basically. So stroke care. 1996 TPA is approved by the FDA for use in acute ischemic stroke. The initial indications are for use within 3 hours of last known normal. This was expanded to 4.5 hours in the extended time window. In 2003, so basically in early 2000, we started to do mechanical thrombectomy for patients with stroke. The initial trial from 2013 called IMS-13 did not show a benefit for mechanical thrombectomy compared to IVTP alone. There were a lot of problems with this trial. It was a very sort of grim and gray day within the stroke thrombectomy world. And a lot of that had to deal with basically IMS-3 started enrollment before these newer stroke devices were actually out on the market and widely in use. And the devices that we use even now compared to 2013 are much better. And so that matters a lot as well. In 2015, between 2013 and 2015, we could not get a stroke thrombectomy trial basically powered or funded within the United States. And so all of these trials that came out in 2015 are from Europe and from Asia. The NIH, you couldn't get money for this basically. So 5 trials came out in quick succession demonstrating that IVTPA with mechanical thrombectomy or mechanical thrombectomy alone was superior to IVTPA alone. And this really changed the paradigm. So starting in 2015, we began to recommend that within 6 hours that patients with a large vessel occlusion undergo mechanical thrombectomy. And if they were a candidate for IVTPA, they also get that as well, okay? There was no demonstration that there was an added risk of hemorrhage or harm to patients who got both thrombectomy and IVTPA. In 2018, we extended the window for mechanical thrombectomy. So 2 trials came out that extended the intervention window for anterior circulation, so ICA, MCA, thrombectomy, LVOs, all the way up to 24 hours out. And how they made that determination was based on this perfusion imaging. And so there's a subset of patients that even though their brain has been starved, of oxygen for a prolonged period of time because of their natural collateral circulation or things like that, have not stroked out the entirety of that hemisphere of brain. And so long as that mismatch is appropriate, they still have salvageable penumbra based on perfusion imaging that the American Heart Association says is entirely reasonable to take these patients for thrombectomy. Granted, what you're looking at in terms of outcomes is very different. So in the past, these patients would have been basically relegated down that pathway of significant swelling to the hemisphere, likely a decompressive hemicraniectomy, trach and a peg potentially, and still with long-term deficits. Now what we're hoping to do is pull back those patients from needing a decompressive hemicraniectomy. Having a decompressive hemicraniectomy in the setting of an acute ischemic stroke adds about 15 to 20 days of hospital stay and is a significant morbidity and mortality for patients. Okay. So now when we think about the spectrum of stroke care, we're talking about medical management, so good hydration, monitoring vitals, secondary stroke and primary stroke prevention, IVTPA, along with endovascular clot removal. No longer is stroke care in this acute setting basically one or the other. Many of these are sort of bridged together, and and we work on them sort of either parallel, concurrently, and whatnot. So the goals of thrombectomy is to recanalize or reopen up the occluded blood vessel. Return of blood flow does not equate to reperfusion of tissue. Okay, reperfusion of tissue is a physiologic thing that occurs. Recanalization is a structural thing that occurs. We are guesstimating at best what, where on the spectrum tissue is, and only time will tell, usually about 24 hours out, how much of the brain we were able to salvage and what parts of it, okay? And then standardization of recanalization. So we stole something from the cardiologist. They have something called the TIMI score, which basically, indicates how much of a blood vessel in the heart has been reopened after a coronary intervention. And when the interventionalist for the brain basically converted to what's called a TIKI score, okay? And so a TIKI 0 means that there is no recanalization, no flow distal to where the blockage is. TIKI 1 means less than 50%. Usually we, say somewhere about 25%. TIKI 2A is less than 50% of the vascular territory seen to be filling. 2B is greater than 50%, but not 100%. And TIKI 3 is what's considered completely normal. So this is now normal timing, normal blood vessel filling, all that stuff. In between TIKI 2B and 3 is this designation that is sometimes used, sometimes not used, depending on where you're at. It's called the TIKI 2C. It means that structurally, all of the blood vessels that should be filling are filling, but the timing of it may not be 100% normal. Okay. So when we do stroke interventions, basically, it's just telescope catheters. We can go in either through the groin or also through the wrist radially. And the goal basically is that we have to snake these catheters from your access point all the way into the major vessels and then up into the neck for the guide catheters. And then the aspiration catheters, these actually have to go all the way up into the brain to the clot interface. And most of the time they get hooked up to a suction aspiration, okay, like this. This is a older penumbra pump. And sometimes we also use things called stent retrievers, which are literally just like they sound. They are these small, deployable and resheathable stents. In the past, we used to always use a stent retriever with an aspiration catheter. When this first started, all we had were aspiration catheters, and people for the most part are, kind of, I'd say 50-50 back to starting with aspiration first and then moving on to a stent retriever if they need to. The main issue is cost. Stent retrievers are pretty expensive. The aspiration catheters are cheaper. And so from a cost analysis standpoint, if you can get the same result with less material, it's probably more beneficial. Okay. This is a picture I've shown before, but this is basically what that clot looks like when it's caught. So this is a stent retriever. You can see the acute plug of clot over here, and this is the aspiration catheter that's been corked onto the clot. Okay. This technique of using the stent retriever and the aspiration catheter is called the Solumbra technique. If we just use aspiration, it's called the ADAPT technique. And there are some patients and interventionalists that only use stent retrievers as a primary way of doing their stroke interventions. It's whatever works best in your hands, basically, and what your facility has available. So the goals of every stroke intervention basically are to take something that starts off as a TK0, a complete occlusion, and make it open and recanalize like this. And so the goal from the stroke trial standpoint demonstrated that people have to get at least a TK2B or better recanalization result in order to do the best. So that means that you have to structurally get more than 50% of the distal vasculature open, and it has to fill, at a pretty reasonable rate. What we're hoping for is, instead of having this as the natural history of large vessel occlusion, to create an outcome that looks more like this. While there is going to be damage, or areas of the brain that have had permanent stroke, hopefully those are limited to what the perfusion scan initially showed as core infarct, and that the rest of that penumbra or green stuff basically is salvaged as much as possible. And we'll kind of go through the rest of the case studies and whatnot. Pre-hospital screening. So there are many established ways of documenting stroke severity within the hospital setting once they get to the ER. The NIH stroke scale, or the NIHSS, is the most widely used, verified one. The problem with it is that it's not a great screening tool. It requires cards. It's probably roughly about 5 minutes to do a full NIH stroke assessment and exam. And so for you guys in the field, what you need is a good screening tool, both to identify stroke, of which there are several, but then also to potentially identify patients who may have large vessel occlusion. Time and time again, studies have shown that if you guys can identify in the field patients who are likely to have a large vessel occlusion and bypass smaller hospitals and centers and send them directly to areas where they can get stroke thrombectomy once they hit the door, that cuts down significantly on the time it takes between identification and intervention, improves patients' outcomes, and reduces, sort of a lot of these other ancillary steps. In Alaska, and particularly in the Anchorage Bowl, the issue is less of a one than like if you're in LA or something like that. There's only 2 stroke thrombectomy capable centers in the state. They're both here at Anchorage, and the question is just which one are you guys going to send it to? So one of the things that has to occur is that we need pre-hospital screening. And so the one that I think you guys use in EMS, that's a very popular one, very well validated, is the VAN score, okay? And the reason why the screening is important is BFAST, Cincinnati Stroke Scale, all these things, they're great for screening for if you've had a stroke or not. But these strokes could be small lacunar embolic strokes, or they could be large vessel occlusions. And so VANS was specifically created to screen for large vessel occlusion, okay? And the criteria basically is that you have to have a focal motor deficit. If you don't have a motor deficit, you are automatically VAN negative, okay? So you have to have at least a drift or weakness in one arm. That's how they define the motor deficit, okay? And then you have to have one of the 3 remaining things. So either vision issues, so a visual field cut, okay? Aphasia or speech issues, and or neglect, okay? And the one thing about it is that patients who screen positive for VAN generally always have LVO, okay? But there's a subset of patients that may screen negative for VAN that still have an LVO. And those are the patients that fall under this, only 90% specificity or true negatives, okay? And so the VAN is great for screening purposes, but just because you're negative on a VAN doesn't necessarily fully exclude you from potentially having an LVO. And that for you guys in the field doesn't matter so much, but from a hospital standpoint, it matters because the hospital, once the patient hits the ER, they can't let their foot off the gas. You have to go through the entire stroke workup as you would for any patient, regardless of that. But, it's helpful. And hopefully as time goes on, we can adjust some of our paradigms for these patients by knowing that they're VAN positive coming in, and maybe having patients and the cath lab and stuff already sort of in place at ready, so that as soon as it looks like, this is going to be a definite LVO, things are going and we're just, rolling to the cath lab quickly, as opposed to sort of waiting every step along the way. So be fast. We've covered this. VAN should be very familiar to you guys. This is the NIH stroke scale. The larger the scale, the more severe your stroke is. In the original trials, you had to have an NIH stroke scale of at least 6 in order to qualify basically for thrombectomy and or intervention. So this is from the original Van paper, and what they were hoping to propose basically was that, this is very similar to sort of what we do right now at Alaska Regional with some caveats. In the pre-Van protocol, meaning before we started screening for LVOs, patient comes in, they get their head CT, they make a decision about TPA, then the patient goes back now to get their CT angiogram, CT perfusion, it gets read, someone calls neuro IR, and then the patient goes to the cath lab. Can take up to 2 hours. This is a pretty, pretty standard timeline in the past. But the hospitals that have implemented and changed their stroke protocols after, pre-screening for Van would be, so someone screens Van positive in the field, EMS lets the hospital know. The hospital is aware of this ahead of time. They might have an LVO. And so they've called people and said, hey, we've got a potential LVO coming in. They are, however, 10 minutes out. And at least everyone is sort of available and ready. The interventionalist is aware of this patient as well and is looking for imaging to occur. And the main thing that saves time would be to get all the imaging done ahead of time in one block, make the decision for TPA with teleneurology. And while all of that is happening, the interventionalists and the radiologists are reviewing these images and saying, hey, we are go or no go for the cath lab. And so once that's done, we just roll right away. Right now at Alaska Regional, for logistical reasons and things like that, we sort of have a hybrid of these things, okay? And hopefully as time goes on, we can streamline this, and that's something for us to deal with as a hospital system and as a protocol in the future. This is currently the Alaska Regional, stroke alert flowchart. It's a little bit busy, but the main thing basically is that we have 2 different sort of paradigms. One is for patients that are still potential TPA candidates, meaning their last known normal was within 4.5 hours, versus patients who are not TPA candidates. Patients who are not TPA candidates will obtain all of their imaging at once because there's not this intermediate step of determining TPA, which as of right now occurs outside of the CT scanner for a lot of reasons that we don't need to get into. Okay. A little bit of a pivot point. So thrombectomy for distal medium vessel occlusions. So if you remember previously, we talked about large vessel occlusions as being those here at the ICA terminus within the proximal MCA branches, but not things that came out into what's called the sylvian fissure in this area or out to the cortical surface. Distal median thrombectomy specifically addresses what we call M3 or sometimes M4 distal cortical branches, okay? This is something that within the field of stroke thrombectomy, we are seeing more and more of, and as time goes on, I think that we will be chasing more distal clots, okay? And there is a rationale for this, okay? So by definition, a distal thrombus or distal thrombectomy is not technically a large vessel occlusion. We defined LVO and the anatomy, beforehand. Main things that people have worried about in the past with distal thrombectomy is that the distal vessels are much smaller. Sometimes they can be 2 millimeters or less. And so do you use traditional aspiration, but maybe with a smaller aspiration catheter? Do you use a stent retriever instead that gets delivered through a smaller catheter? And the main thing also is that the further and further out you get, into the brain, the longer and longer those catheters and that trajectory is. And basically, the greater the distance you have to pull in order to pull your aspiration catheter or your stent retriever out of the clot back into the normal circulation. And so there's always concern that greater distance could potentially, add more shear force or potentially injure blood vessels more. And so are we going to be at a higher risk of rupture and things like that? We don't have any long-term data on this yet. And so this is something that, in ongoing trials, people are looking at. And then more importantly, what are we actually hoping to gain, right? So let's say someone does have a distal thrombus and a distal MCA branch. Are we just doing this to make the pictures look good, or is there a point? And the answer is yes, there is a point, and it's basically what the symptoms are, okay? And so in particular within the MCA, distal branch occlusions that come out into the areas not highlighted in yellow rarely have significant stroke symptoms associated with them, okay? But in areas that are highlighted under this box, these patients, while their proximal vasculature may be clear, if there is still a distal clot that goes out there, they can have significant symptoms, mainly because some of these distal branches go directly to the motor cortex. So they can still have a pure, very dense motor or sensory neglect or weakness, okay? And also, and sometimes go directly out to speech and things like that. And so one, could reasonably argue that while, yes, they don't have a large vessel occlusion, what they do have, though, is still a pretty significant stroke symptom that is in eloquent cortex that has a significant debilitation in the long term. And so it may be worthwhile to chase after these, okay? And so that's where sort of distal thrombectomy is. So, Is it just distal? Nobody cares. The main thing is that where are the symptoms and where does that blood vessel lead to? That probably matters more. So any questions up until now? No? All right, so we'll go through some of these case reviews, okay? So one of the things, just as a reminder, we judge long-term outcome by this thing called the modified Rankin scale. 6 is death, 0 is completely normal. Most of us function somewhere between like a 1 and a 2. 3 is, so in the past, 0 to 2 was the cutoff or was considered a good outcome. 3 is kind of this weird nebulous no man's land, and it kind of, encompasses a lot of different patient outcomes. 4 and 5 are patients who are not living at home. They're living in some sort of assisted living, ALF, things like that. So this is a 75-year-old lady who came in, very lovely lady who has known diagnosis of AFib, but was not regularly taking her Eliquis. And we had a mild delay in door to needle time because there was a lot of back and forth about whether or not she was actually taking her Eliquis versus not. She had brought in her pill bottles with her, and one of them was for the Eliquis, but she'd not actually been taking it. And so ultimately she was diagnosed with a right MCA thrombus and clot. And took her to the OR once we figured out the TPA situation, basically. And I'll show you the pictures here, basically. Her perfusion imaging, unfortunately, was all manner of messed up from a technical standpoint, and so it wasn't all that helpful. And so we wound up taking her based on what's called her aspect score, which is the Alberta stroke, scale based on non-con CT imaging. Her time of onset, which is within 4.5 hours, basically, and the fact that she's otherwise young and had a pretty dense hemiplegia. So in her situation, she actually had a M2, so an MCA bifurcation clot. You can see this is the initial. You see normal filling over here. Here's a normal branch of the MCA, and then this stump right here. Okay. After the first pass, we got the proximal portion of the stump open, but there was still this part going out to an area near the motor strip that was not filling, basically. And so we went after this distal thrombus, essentially, with our aspiration catheters and got all of this open, okay? Long-term, her stroke burden was actually, relegated to some pretty non-important, non-eloquent right temporal lobe areas. This is the stuff in her sylvian fissure and everything else. Okay, she did really well. She wound up actually going to rehab, I think, 48 hours afterwards, and then was discharged not there long afterwards. And I saw her for 30-day follow-up. She's back at home, back to her church activities. She has a technical modified Rankin of 2, so she doesn't drive, okay, what she was doing before, but she's independent with ambulation, cooking, cleaning, all that stuff. And she has restarted Eliquis, and we have confirmed with the pharmacy and reiterated to the patient why this is very important. Interestingly enough for her, on her initial head CT when she came in, she had evidence of old, infarcts into the bilateral hemispheres related to thromboembolic event from her AFib. This next patient is rather interesting. It's a 46-year-old male who was, brought in basically. He has some baseline cognitive things related to, as his wife put it, probably prior stroke in the past. He also has this pituitary macroadenoma that's been there for a while that people were following. And his main issue actually was aphasia, confusion, and slurred speech. And so, his aphasia was very, very significant, very dense, both expressive and receptive aphasia. Strength-wise, everything was okay. And on his imaging, you can clearly see that he's got, this large penumbral area, basically, that goes out primarily to the speech cortex, so both the Broca's and Wernicke's, okay? And so while, his initial imaging didn't show like a big MCA clot or anything like that, he had a very dense eloquent deficit, and the concern was that he was not going to get better and was not improving, even though TPA had been administered, and so he was taken to the cath lab. Okay, there was a lot of back and forth initially about whether or not we should take this person or not, and I think I got called a little bit late about this as well. The other issue too is that during his initial TPA infusion, his blood pressure was very poorly controlled, and so there was a lot of sort of titrating and optimization in that setting. And so in his situation, kind of the same thing. This is the ICA terminus coming up, left ACA, left proximal MCA. In the past, our definitions of LVO basically were just in this area. You can see right here, there's a stump of a blood vessel that is not filling distally. This one went directly to where his speech centers were. And so you can see beforehand versus afterwards, the filling of this distal vessel, okay? And ultimately, his speech was actually at the very distal end of that vessel, but this area, which is where his primary speech cortex would be, has been spared. Okay. Post-procedurally, his speech did improve. It took about 36 hours before he started talking again, but he was ultimately discharged, I believe, to home, if memory serves correct. I saw him at 60-day follow-up, and he has a modified ranking of 1. So he is back to driving. Both he and his wife feel that his speech is back to baseline, both understanding and speaking. His main issue is that he continues to have some mild cognitive memory issues and also some headaches. So overall, another distal thrombectomy. And again, the decision point here was primarily for eloquent speech, cortex, and language. The next patient is a 65-year-old male, basically, who presented with ultramental status and right-sided hemiparesis. Okay, last known was several hours prior, and was doing okay basically, and then started to have issues with the right side of his body, along with expressive aphasia and everything else. He was a TPA candidate and was taken to given TPA and then taken to the cath lab. When we saw him initially, I believe his NIH stroke scale was something on the order of like 19 or 20 or so. He had basically a dense hemiparesis and neglect on the right-hand side, along with dense expressive and receptive aphasia. Per the patient's wife, he had no other health issues, maybe some hypertension, had a heart attack about 5-10 years ago, was a pretty high-functioning individual otherwise. So this is his CT perfusion. The pink are areas of established infarct, meaning these are things that we were not expecting to reverse, even if the blood vessel could be open. The green over here is everything that is considered, penumbra, meaning everything basically that is undergoing some form of cell death and change, but there is the possibility and high likelihood that if the blood vessel can be reopened and we can reestablish blood flow, that these areas will be salvaged, okay? Ultimately, at 24 hours, as is our protocol, we get an MRI, and all of the bright spots in MRI basically tell us which parts of the brain and what areas have had a permanent stroke. And what you notice is that all of this stuff along the outer edges or the cortex has been spared. It's only the small area on the inside over here, which correlates with this stuff over here, that actually has undergone permanent stroke. So intraprocedurally, this is what this gentleman had. You can see this is the internal carotid coming up on the left-hand side. And you basically see this abrupt lack of filling into the rest of the brain over here. All of this stuff over here are actually the scalp vessels from the external carotid, okay? At the end of the procedure, after the aspiration, you can see that this blood vessel has opened up, and all of this is the cortical vasculature going out into that left hemisphere that wasn't previously filling, okay? This guy did really well. About 24 hours after the procedure, his speech was back. He actually started moving probably within a couple of hours after the procedure. And again, he was, his symptom onset was very, very short. His time to TPA and his time to cath lab was really, really short. And so all these things, led for a really great outcome in him. He was discharged, if memory serves correct, about 2 or 3 days after the procedure to home. And he is now, a modified Rankin scale of 1. So he's driving back to all of his prior activities. Fatigue is his main complaint. As an outpatient, he was diagnosed actually with atrial fibrillation, which makes sense. His carotid arteries are completely clear during the procedure, and started on Eliquis. And so that's where he's at right now. Next patient is rather, young individual. I think she was in her late 50s, if memory serves correct, who presented basically with weakness on the left arm and left leg, along with a significant left-sided neglect, okay? She was found by family members after what they thought was initially a fall, and so last known normal was well documented. She did get TPA, and on imaging had evidence of a pretty significant, what we call tandem lesion, so very significant right carotid artery stenosis in the neck, along with intracranial clot as well. So this was her initial perfusion scan. So these areas right here that are purple, again, are thought to be established as, ischemic infarct and are dead. All of this green, okay, is much larger than the purple, and these are the areas of the brain that are still potentially salvageable. After her procedure at 24 hours, this was, a pretty indicative representation where her stroke is. So all this stuff that's out over here is free of stroke. That's mainly the deep structures, which we could see previously over here that have established infarct. And so this was this patient's procedure. This was actually her right common carotid arteries that came up. There's a significant plaque that's here, very critical stenosis. And you can see we do have some contrast or blood flow filling past it, but it's very, very slow and sluggish, okay? And so the first move is to bust through this area, get through that. Once we got past that area of narrowing, you could see that as the blood flowed distally, it basically abruptly stops right here. And the reason for that is she has what's called an ICA terminus clot, meaning at the proximal intracranial internal carotid artery, there's no further blood flow. After several passes of aspiration, you can see the remainder of the MCA and ACA vasculature opens up, okay? This is the clot that we actually sucked out of her brain here. And then on the way out to deal with basically this carotid disease, we wound up doing a balloon angioplasty, okay? Some patients, the balloon angioplasty is not enough to get things open and remain open, for continued flow. And in those patients, we have to make a decision sometimes about acute stenting. The downside about acute stenting is that just like with coronary artery disease, if you stent someone, you commit them to dual antiplatelet therapy for at least the next 3 months, and especially for a patient where even though you've gotten the blood vessels open, we don't know exactly what the volume of infarct is going to be like if they're on aspirin and Plavix. And let's say, turns out, even though we got everything open, it wasn't done in a timely enough manner to be able to salvage significant portions of the MCA territory, and they swell or they have a hemorrhage. And need a decompressive hemicraniectomy. Now you're really sort of stuck between a rock and a hard place. And so we try to avoid as much as possible, but sometimes you don't have a choice. So at 60-day follow-up, she has a modified ranking of 1. So she's back to driving, back to grocery shopping and everything else. She still does have weakness that's particularly worse when she's, tired and she has headaches, okay? She does unfortunately continue to smoke, which was a big point, especially with her carotid disease. But her carotid Dopplers at 60 days did not show any evidence of restenosis in her, and it's less than 50%. And so right now, she doesn't really meet criteria for carotid intervention. She's actually going to be moving back to the lower 48 in the Midwest to be closer to family. And so we'll be transferring the rest of her long-term, stroke reduction and carotid disease follow-up to somebody down there. Any questions so far? No? Okay. So the next thing basically is some of our updates from the initial May 2020 stroke review. So this was the gentleman who came in from Fairbanks. So interesting story. So this is a guy who had been having some paroxysmal atrial fibrillation that he had actually been tracking with his iWatch. And kind of in the 2 weeks leading up to his initial stroke presentation and whatnot, had been having more and more episodes that were being pinged off of his watch, telling him that he was an AFib. He had a discussion with his cardiologist outside about whether he should start anticoagulation, but they felt that his CHADS-2 VAS score was actually pretty low as he didn't have hypertension otherwise, had never had a stroke, and everything else. Unfortunately, that sort of changed once he had a stroke, but he basically got TPA at Fairbanks and then was transferred here. We did a stroke intervention for him, and post-op wise, he started to regain some functions in the left upper extremity, but was still pretty weak. He ultimately went to inpatient rehab, I think about a week after his initial stroke, intervention procedure and whatnot. This was his initial perfusion scan versus the established infarct, and this is sort of what he was left with. He had a complete, M1 occlusion, so coming up intracranially, no filling of the MCA. After several passes and pulls, we were able to get all of this open, and this is sort of what the plug of clot looked like. He spent about 2.5 weeks in rehab. He is also left-handed, so it's his dominant, hand. And I saw him for 4-month follow-up more recently. He's discharged. He's back home in Fairbanks. So he is back to now walking without the assistance of a cane and whatnot. His wife feels as though that she could probably leave him at home safely, but has been hesitant to do so. He continues to have some left arm weakness. The hand is better than the arm, but proximally, he's able to basically get it about anti-gravity, so about a 3 out of 5, but continues to work with outpatient PT. He and his cardiologist did start him on Eliquis for treatment of his stroke. And so his modified ranking at 4 months out is still about a 3. I am optimistic that as time goes on, I told this to he and his wife, that he likely would continue to improve. And certainly if she began to feel more comfortable with, leaving him at home and whatnot, his modified ranking also drops as well, secondary to that. And then the last one that you guys are probably pretty familiar with, this was the transfer from Matsu. This is a very young patient. If memory serves correct, he's like in his late 40s, and also a morbidly obese patient initially. Had clear elastinonormal with facial droop after watching television with his significant other. and got TPA and whatnot. And there was a delay in his transfer, mainly related to the fact that he initially his build weight was not what it really was. And so I think when they came with fixed wing, they recognized that he would not be able to safely accommodate for med flight. And so then they had to wait to find an ambulance. And so he got here pretty late and had already pretty established areas of infarct in his brain already. But again, young guy, if, we don't do anything, the natural history is complete infarction of that hemisphere, along with likely the need for decompressive hemicraniectomy and everything else. And so we took him, to the cath lab. We elected not to get an additional CT perfusion, mainly related to his body habitus. And I did not believe that, it was going to change my plan for workup and whatnot. So on his initial head CT, you can see ACA is filling, and there's a lack of filling at the proximal ICA. And what he had was kind of the same thing, basically. He had an ICA terminus clot, so no filling intracranially. With the first pass, we were able to open up the proximal portions of his MCA, but there's still a filling deficit distally. And with the second pull, basically, we were able to get the rest of this vasculature open. And this is what one of the clots looked like. Even though we were able to recanalize and whatnot, his, post-thrombectomy CT scan clearly shows established infarct in this area. Okay. But surprisingly, he started to improve, about 2 days after the procedure, started to be able to lift his right arm and everything else. And when I saw him at kind of 60-day follow-up, he, was using the arm, still had the facial droop, but was working on losing weight and whatnot. And I saw him more recently, a 5-month follow-up, and he's lost about 100 pounds. He is back to ambulating without the assistance of a cane. He still has some right hand clumsiness, but has actually learned to write and draw with his left hand. And so he has a modified Rankin scale of 2. Okay. They are still working with him about whether or not he may actually have likely a cardioembolic source for this. And so they're talking about starting him potentially anticoagulation. But he looks really fantastic and phenomenal, all things considered. So, and that's, that's one where, there was a delay secondary to, his body habitus and ability to transport. But even with that, because of his young age, I really do believe that, he's made a very, pretty significant, remarkable recovery, all things considered. And that's that basically. So mechanical thrombectomy, early infield EMS identification of potential LVO candidates matters. But the corollary to that is that we also, as a hospital system, have to work on streamlining and changing our, LVO versus non-LVO screened patients and how we sort of deal with them once they hit the door to optimize time. Time is brain. 1 to 2 million neurons die per minute during an acute ischemic stroke, and certainly during an LVO. And anything that we can do to decrease the amount of time it takes for us to get the patient's image, make a decision about TPA, and then more importantly, get them to the cath lab so we can get to the clot, all of that matters. Patients recover more quickly and have a better outcome the sooner you can do these things. Makes total sense from a physiologic standpoint as well. Okay. The other thing too is that as a hospital, even if someone doesn't screen positive, like on a VANS or things like that, if they come in as a stroke, we still have to, as a hospital system, follow all of our protocols as we normally would, assuming that someone could be a potential LVO. More recently, actually just a couple of days ago, we had a patient that was VAN negative in the field, but had a very dense, hemiparesis, hemiplegia that was absolutely, intervention candidate. And we had a significant delay as a hospital system after he hit the ER in terms of getting that sorted out and getting him to the cath lab. And so that's something that, for us as a hospital and as an ER, we need to work on. Distal thrombectomy. So the field is headed towards this. I do think that there is a role for it, but I think that it has to do with anatomy. Making the picture look pretty, it makes us feel good, but if it's not going to ultimately benefit the patient or comes at the expense of a potential risk from a hemorrhage or vessel injury standpoint, it doesn't make sense. Most of the time when we're talking about distal thrombectomy, it's either in the context of an initial presentation that has a large amount of eloquent, deficit. So pure, aphasia, either expressive or receptive, or pure motor symptoms. I think that it is worthwhile to consider these patients. Most of the time, these patients will also have a pretty significant penumbra seen on their perfusion images. So it's not just sort of like one small area and whatnot. The data of this, the safety of this, the devices and everything else, this is something that is sort of an ongoing thing. There are many registries that are looking more and more at the data collected from distal thrombectomy. Okay. And so I think that as we go forward, we will also need to consider, this as something that, may need to be gone after and chased and whatnot. And then stroke recovery. We usually see patients in my clinic after stroke intervention somewhere between 30 and 60 days, just depending on if they went to rehab and all that stuff, and to see sort of how they're doing, at first blush. These patients are doing better, they're back at home, but most of them are still, with some debilitation and whatnot. The other thing too is to ensure that they are getting the appropriate outpatient stroke workup as well. So do they get their, 30-day Holter monitor? If they have AFib, do they get started on Eliquis? Do they see the stroke neurologist? Is someone following their carotids? All these different things. But stroke recovery is usually on the order of 6, 12, 18 months, even sometimes up to 24 months or 2 years. And so, we usually don't see patients all the way that far out, but it is something to counsel, your patients on as well. And again, patients' overall age matters a lot. Okay. That last patient that, George Davis that we talked about, he was a young patient that was pretty far out, even though he got TPA and had, pretty established infarct even after thrombectomy, but he has done really well and he'll continue to do well because his overall age and functional status leading up to this was so good. And time to recanalization matters, and also time to TPA matters. The patients that recover the quickest and that do the best are those who have had the shortest amount of downtime, just like the heart. That's no different. All right, that's about all I've got.
Excellent. Thank you, Dr. He, for sharing your lunch break with us, as well as Tammy. Thanks for joining in. And for all the medics that are out there, or the medics that are going to get this, please bring me your ideas on what education you guys want next. It really helps give me a direction on where to take this and kind of get you guys what you are interested into. With that said, thanks again, Dr. He, and I will end the recording and you can go back to your day.
All right, sounds good. Thanks, DJ.
Thanks.